Well, good morning, and welcome to the Welcoming Committee's Autumn Respiratory Virus What You Should Know Now update. I'm Barry Eben. I'm a member of the Wellness Committee, and I'll be helping to conduct this meeting. Before I introduce our speaker, I want to ask you to take a moment to orient yourselves a little bit to today's presentation and discussion. And what I would suggest is that in a moment we take a minute and that you just stop and think for a moment about what kinds of assumptions are you currently making about your own health with respect to the viruses that hover around us. What kind of assumptions are you making and what's your current thinking about your own safety and about community well-being in the context of the virus environment? And I'll come back to you in just a few seconds. Okay, so the way this meeting is going to go is that our speaker will present for about a half an hour, perhaps with some questions intertwined, and then there will be a period for questions and comments. Following that, we have a couple of discussants who will join in. Lauri Warfield-Larson, our multitasking COO who serves as our medical officer, essentially, and to whom we, I think, all owe a great debt of gratitude, and Dr. Findlay Wallace, who has served us all well on what was the COVID task force and is now called
Community Health Task Force.
The Community Health Task Force. Its scope has been broadened. And Lauri and Findlay will add comments, and then we will have time for additional questions. The plan is to run as late as 11:30. We may end earlier. The program will be broadcast, I'm afraid at a time I cannot say at this point, will be rebroadcast on HHTV, and we'll get that information out, I hope, through the alert. And it will also be available on YouTube. Okay. Our speaker today, Dr. Christina Coulter, is a person who ably wears many hats. She has a doctoral degree in behavioral science from the University of Washington. She is an A.R.N.P with a gerontology specialty. She is a member of the faculty of the prestigious University of Washington School of Nursing, where she is currently the director of curriculum development. She has a specialty in training nurses in working effectively with folks with dementia who are experiencing and presenting behavioral problems. And in fact, a little over a decade, well, I'll leave that to you. I'm sorry. None of that are the reasons that Christina was invited to speak today, but I thought her background is rich and interesting and want to share it. Christina is also a family practitioner over at Swedish's comprehensive care here on First Hill, and she was selected to be the person who sat up and ran and provided service at Swedish's walk-in respiratory disease clinic throughout the pandemic, for which I thank you. She has stayed abreast of the field and is here today to help us stay abreast of it. Would you please offer a warm welcome to Dr. Christina Coulter?
Thank you. That was quite the introduction. I kind of almost forgot I had done all that. Yes, in March, I think it was March 15th of 2020, when things were kind of starting to become evident this was a bigger problem. Closer, closer. That? Or I'm going to do that, because I like to walk around. So in March of 2020, our CMO came to my office door early one morning and said, this is going to be bigger than we realize. And I said, yes, I think so. And he said, will you come downstairs and open what we called a disaster clinic at the time? It'll be a couple weeks. 2.5 years later, I was still there. And we saw the pandemic and its impact on our community change and evolve over time, just as the virus evolved. And so during that time, I researched everything I could, read all the evidence about the changing strains, what our management options were and were not at certain points, and kind of developed an awareness of all the science around that, and then helped our clinicians as well understand what was happening and what we needed to do to help our community. And then at a certain point, we realized some of these symptoms were starting to persist, and they weren't going away like we told everybody they would. And that was what was known as long COVID. And we realized at a certain point that was not just respiratory symptoms. People were having a lot of other long-term symptoms related to COVID that we had not anticipated. So then I started doing research about what that looked like, how we could help manage that. And still today I have a cohort of patients that have long COVID, or what we now call PACS, post-acute COVID syndrome. And we'll talk a little bit about that today. So basically, let's get this turned on. What we're going to talk about today are the projected circulating viruses. So now that we've all re-entered society, and I'm here talking to you without a mask, and I would say, you know, probably when we go out into the community, about a third of us are masked and 2/3 aren't, depending upon where you go and the circumstances. And the consequences of that, for better or for worse, are that now some of those other viruses are starting to circulate. You know, back in 2020 and 2021, very few of us got just regular colds like we used to get. Well, that's coming back, as will influenza and those other things. So we'll talk a bit about those things. Other causes of respiratory illnesses besides viruses, we'll review those too. And then we're going to talk about the differences, what you can do about them, and the treatments, if anything. That includes supportive measures. And I'll talk about what I mean about that. We're going to talk about long COVID, or like I said, post-acute COVID syndrome, what it is, what it isn't, because there's a lot of confusion even amongst clinicians, as to what that looks like and what it means. So we'll talk about that, and how to avoid it, because there are some ways you can avoid it. We're also going to talk a little bit about the psychosocial parts of the pandemic. You know, I think a lot of us are still a little in a stage of adjustment after the pandemic, and so I think it's important to acknowledge that and talk about that a little bit and what that looks like for each of us going forward. All right, so we'll dive in. So this season, what we expect, what the CDC and the World Health Organization expects to see are COVID. That'll still be the dominant respiratory virus that most people are concerned about and at risk for. So that's the big one to look for, and we'll talk quite a bit about that one. Influenza A and B, like I said, those are going to make a comeback. The projection is more so this coming season than in any season since 2020. COVID is still a much higher risk, still kills 6 times more people than influenza, but we do still need to be aware of the flu. Respiratory syncytial virus. How many of you have heard about respiratory syncytial virus? Oh, good, we're all doing our job for public health. So respiratory syncytial virus typically is transmitted with children. Those are the ones most at risk, and older adults. There's now a vaccine for respiratory syncytial virus, thank goodness, because it is not fun, and it is not quick, and it is quite harmful. So thankfully, there is a vaccine, and it is effective. Common colds, rhinovirus, parainfluenza, other coronaviruses. There are other coronaviruses that are not SARS-CoV-2, and those cause common colds. Rhinovirus, parainfluenza, these are the ones where you get the sniffles, you might get a little sore throat, you might get a cough, but the reality is these days, sometimes COVID looks like that, sometimes influenza looks like that if we've been vaccinated. So that's one of the reasons why testing for COVID is important. Even if you think it's just a cold, it's important to test. You're going to hear me say that about 17 more times because it is truly important, especially in a community where we are densely packed. And I don't just mean Horizon House, I mean Seattle in general. We really want to avoid spreading this, and even though it might feel like a cold, it could be COVID. So we'll talk about that too. Other severe respiratory viruses. So some people call these killer colds. They just feel a lot more severe than a regular cold. Metapneumovirus, adenovirus, and bocavirus. So these are the colds you have for 2 to 3 weeks and you're just exhausted. The symptoms are really severe and the doctors can't seem to tell you what it is because we don't usually have tests for these. There are respiratory viral swabs we can do, but they mostly target the more dangerous viruses like COVID and flu. So those are out there also. They can cause pretty significant illness, but they typically won't land you in the hospital. They'll just keep you in bed for a couple weeks, which is not good either. Bacterial infections, pneumococcal pneumonia, which is caused by Streptococcus pneumoniae. That you can get a pneumonia vaccine for. That is a bacterial infection, and that's what your doctor's giving you Prevnar for, or one of those other pneumococcal vaccines that are out there. Pertussis, also known as whooping cough. I'm sure many of you recall whooping cough with your kids. Adults can get it, and that is caused by Bordetella pertussis. We also vaccinate for that with the Tdap, and you need that every 10 years. So luckily, it's combined with tetanus, so we're protected from a couple different things. Allergies. We all, when we get congestion and cough and sore throat, we sometimes forget that we all can have just allergies. And whenever I say allergies, I don't mean I see a set of pollen-laden flowers and I start to sneeze. We can develop allergies to dust. We can develop allergies to various things throughout the course of our lives. It doesn't have to be a childhood thing. Environmental particulate, and this is particularly important for fire season, where we are right now. Even though we look outside, it looks clear, the air quality is not as great as it could be because there are still fires burning, and that can cause some of us to have congestion, a little bit of a sore throat, and sometimes even a cough from some of that congestion. So it's one of those things to be aware of. If you're not feeling quite right and maybe your throat's a little sore, you have a cough, you're feeling a little congested, it could be any one of these things. But the bottom line is we want to make sure it's not one of the more serious things like COVID, so you know what to do to help your community. That's why we test. All right. So, any questions so far? Okay. Have we recovered from the pandemic? How many of you feel like we've recovered from the pandemic? The pandemic's over. Okay. How many of you feel like we're still in a pandemic? Nothing's changed. Okay. All right. So according to the World Health Organization, we have now moved into endemic status. And what that means is it's still a constant presence. It's still something we need to be vigilant for. It's still something we need to think about and prepare for, plan for. But we now have resources. So pandemic is when it's spreading out of control and we have very little resources to contain it or control it. And it's going to overwhelm our health system, which we saw happen. When we're in endemic status, we have control measures that are working, and we have treatments available and prevention that will keep people out of the hospital and keep our healthcare system available to care for other things like heart attacks, strokes, things like that, broken legs. So that's the difference between pandemic status and endemic status. The prevailing wisdom is that we are now in endemic status whenever it comes to COVID. So we're not out of the woods, but we see a clear path forward. That's the analogy. So the other thing to know about that, just because we've reached endemic status does not mean that COVID is no longer a risk. COVID is still very dangerous. It very much kills people every year, and it has long-lasting consequences. Even if you don't see them or feel them, each COVID infection can be detrimental, and there can be cumulative effects. That being said, at least if you get COVID now, there are things we can do. So the risk is less, but it's not gone, is the take-home message. So, strains. You know, you hear in the news a lot about the different strains. What does this look like? What does that look like? For most of us, the strain actually does not matter. Why we care about strains is because we want to know how contagious is this one? Where do we need to place our kind of risk tolerance? That's why we care about the strains. The current ones, Iris, EG5, you'll hear about that one in the news. BA286, Purola, and those are both descended from Omicron. And then there's a new one called Fornax. It'll probably share dominance this coming season. The only reason I bring these up is because when you hear about those, the next natural question for a lot of people is, will the COVID booster cover those? And there was a study out of Sweden just recently that said that yes, the new booster does provide protection against all of these variants. This is just a family tree of some of the COVID variants because I think it's interesting to see how much it has mutated. If we were to compare this with a family tree of the influenza virus, it would look much, much bigger. The influenza virus has been doing this for over 100 years. COVID will continue to do this too. It's just a way to say every virus mutates and we formulate our vaccines according to these things. So, COVID, the most important things. What are the typical symptoms? Fever, headache, fatigue, malaise. Most of you know about these things. A lot of patients I've seen in the past couple of weeks who have COVID present primarily with a headache, muscle and joint pain, and congestion. Again, that's very similar to a lot of other ones, so it's important to test with those home tests. There are currently 3 vaccine boosters that are approved, Pfizer, Moderna, and Novavax is the new one. That is a protein subunit. Its effectiveness is good. It's got valid data behind it. The mRNA is still considered superior. Available treatments. Paxlovid stops the virus from replicating in your body. The best analogy that I have so far for what Paxlovid does, imagine the race between the tortoise and the hare. So the hare is the COVID virus that's replicating in your body. Your body is making antibodies from that cookbook vaccine that you got as fast as it can. It's the tortoise. What Paxlovid does is it grabs the leg of that hare and holds it back so that your body can make antibodies as fast as it needs to while the virus is not replicating. It is quite effective, and it's generally well tolerated. A little bit of stomach upset, but it is well tolerated. And the important thing is to get it started as soon as possible. So as soon as you have one of those little tickles in your throat, congestion, do a home test. If it's positive, call your doctor. If it's negative, we've had some false negatives early in the course of the disease. So we ask that people test on the first day and the third day. You're still eligible for Paxlovid at that time. So don't take one test at its word, check again. That's the prevailing wisdom. Molnupiravir is for people who are on a medication that conflicts with Paxlovid. And there are a few medication interactions. And your doctor would be able to look over your med list and tell you what those are and which one is most appropriate for you. Symptom management is the other piece. So there are lots of ways to control the cough, lots of ways to control the congestion, headaches, aches, and pains. And that's different for each individual because we all have different health needs and things we can take and can't take. So talking to your provider is the best way to figure out what's best for you. Questions? Yes.
I've heard reports that people taking Paxlovid, they feel well after they've started taking it, and then they
Yes.
feel bad again.
So that's known as rebound COVID. And that is a thing that happens about 25% of people. A quarter of people who take Paxlovid will get rebound. Thank you for bringing that up. The thing about rebound, it's annoying, it's awful, nobody wants it. The thing to know is, even if it happens, your risk of complications, your risk of developing a more severe cough or pneumonia or ending up at the hospital is still eliminated. Almost down to nothing. It's less than 1% risk of complications if you take Paxlovid. And if you develop rebound symptoms, that's still the case. So that's the benefit of that stays intact. Yep.
Is there any place where one can still get free test kits?
Not that I'm aware of. Yeah, I know. Yes.
Let's repeat the question.
Okay.
So after the booster a year ago, the next day, developed severe dizziness, high. And I was just really sick. And it was more than the rocks in my ear
Yeah.
being out of place. And it lasted a long time.
Yeah.
And I did not get another booster. And I'm wondering what your suggestion is to people who've had a really bad experience after a booster. And I've always had Pfizer. Should I try the one that isn't mRNA? I don't, honest, it was really, it just put me off of shots for a long while.
And you're not alone there. I've had quite a few patients who've had difficulty with the boosters or the initial vaccine. Conventional wisdom suggests most people will have some sort of response, some sort of symptom profile that occurs usually anywhere from a day to 2 to 3 days after a vaccine. That's your body's response to that antigen and learning how to make some antibodies. Some people have a really significant response and they don't tolerate it well. The short answer is it's so individual, it's hard to say. There's no way to know if the Novavax will be better or worse. And some of us look at the risk versus the benefit. Is it worth feeling crummy for those, however long it was, a week, 2 weeks, to have that protection, or is it not worth it to me? And that's an individual choice with your doctor. I'm gonna go here and then I'll come over here.
I have finished, I hope, with COVID. My doctor has told me that I should wait 3 to 4 months before getting the booster, the vaccine, to go ahead and get the RSV and the flu. Does that mean that I have a short-term immunity? Is that the reason to wait for 3 or 4 months?
Yes, the current science tells us that once we have a natural COVID infection, we have a substantial immunity Our body has already learned how to make those antibodies in a natural way and can do so again quickly. So we have an immunity that lasts what we think anywhere from 3 to 6 months. Getting the booster somewhere in that last part of that window is what's recommended currently.
We're accumulating expired COVID tests,
Okay.
even after the extensions. Should we just now throw them away, or will they be extended and extended?
So there's no way for me to know that, but what I will tell you is I have read from the CDC that they're not planning to extend those expirations any longer. That if it's more than a year past the expiration date, it's probably no longer valid. Yeah. All right.
We got one more.
One more.
Are monoclonal antibody pills still available? Is that another one of your treatments?
So monoclonal antibodies were an infusion, and they're no longer available. They've stopped formulating that.
Okay. Well, I was told last year that I could not take Paxlovid because I took Eliquis,
Okay.
and a lot of people take Eliquis.
And
what do you take?
molnupiravir is the alternative, but it's not a monoclonal antibody.
Okay, so the second one is what
Yes.
you take now. Okay. Thank you.
Yep. You're welcome. Yes.
Hi. I had mild COVID in February
Okay.
and later on in early August.
Okay.
So should I wait to get the booster? I have everything.
According to what the recommendations in the current science says, 3 to 6 months, within about 3 months, wait at least 3 months, and then 3 to 6 months, get your booster sometime in that window.
Okay, thank you.
You're welcome. All right. Anybody else? All right, I think we're going to go on to flu. Most of you are familiar with the flu. If you've ever had the flu, it is unforgettable. It's pretty awful. Currently, these are the symptoms. Right now, there's the flu zone high dose, which is what I recommend for all my patients over 65. So definitely any flu shot is a good flu shot, whatever you can get, but I do recommend the high dose. Flu is going to make a major comeback, so everybody please think about getting a flu shot. Available treatments if you do get the flu, we have Tamiflu, which that has a similar activity as Paxlovid. It helps to reduce the virus replication. It also does have some side effects, usually stomach upset and a little bit of dizziness. But again, same with Paxlovid, you really need to start it as soon as possible for it to be effective within 5 days of symptom onset. RSV. So often it's transmitted by our wonderful little children. They typically bring it home. A really serious cough. It causes major inflammation in the airways and a significant cough that can last really for about 4 weeks at its longest. Most people, 3 to 4 weeks. And I have had patients end up in the hospital because their airway was so compromised. So it's not something to be taken lightly. And the vaccine is now available, and that's new this year. So symptom management really is the only treatment. Some people develop pneumonia whenever they have respiratory syncytial virus. We treat that with antibiotics typically, but it's considered a secondary bacterial infection. It's a virus that caused it. Common colds, we all know what those are. There are no vaccines for the common cold. Symptom management is the only treatment. Those typically don't last as long. 5 to 10 days is the conventional wisdom. I had a mentor who was a geriatrician who had been doing this for a very long time, and he used to say, a cold is 3 days coming on, 3 days with you, and 3 days leaving you. And honestly, ever since he said that, I monitor each of my colds, and that's pretty true. So, but again, no matter how mild it seems, please test. That's the take-home message. Severe respiratory viruses, killer colds, generally they last longer, anywhere from 1 to 3 weeks, and it's impactful. It feels like you either have the flu or COVID. So if it's not one of those two things, it could be one of these metapneumovirus, adenovirus, or bocavirus. So also important to see your doctor when and if these occur, just to make sure that there's not a secondary infection developing. Yes, it can cause pink eye. There's a viral pink eye that comes with some colds. Couple of things to keep in mind with this coming season. Every human body responds to viruses, environmental particulate, and bacteria differently. The reason I stress that, and I read it, is because one person may have COVID and have a completely different symptom profile than you might. So just because your friend in Arizona had a certain set of symptoms and they had COVID and you have different symptoms does not mean you don't have COVID. I can't stress that enough, and I talk about that all the time. Every human body responds to things differently. So we all have our own unique way of having a cold or COVID or the flu. So it depends on prior exposures, what you've had before, your general state of health, how robust is your immune system, how overactive is your inflammatory system, all of these things. So vaccines are intended to help prime the body. Whenever we had treatments for COVID, like monoclonal antibodies, and we had the vaccine coming out, people would ask me, what's the difference? So this is how I explained it. Before we had the vaccines and before we had any treatments, it was like somebody came to you and said, bake a cake from scratch, you don't get a recipe, good luck. Right? Whenever we got the vaccine, that was like somebody giving you a cookbook. That's a recipe book. It's a little easier to follow. Usually you can make that cake quicker and more effectively and more efficiently. Monoclonal antibodies, that was like going to the store and buying a pre-baked cake. And it took care of it. Unfortunately, we don't formulate that anymore because they have to be formulated specifically for those variants, and it's multiplying fast and rapidly. So they've stopped doing that now that we have Paxlovid and the vaccines. So just to give you an idea, vaccines are the cookbook so that your body can make that cake itself. They do not stop you from catching something. That's one of the things that I wish we could tell people more. We can't stop you from being exposed. Vaccines can't put up a magic bubble, but they will give your body the best chance to fight things off quickly. I have a lot of people come in and they have caught COVID, but I got the vaccine. Yes, and that's why you're at home and not in the hospital. So just a reminder, vaccines are intended to help you fight off whatever you catch and do it safely and effectively. They do also dramatically reduce your risk of complications, like we talked about. All right, next.
I have a question.
Yes.
Over me.
Yes.
We then have 3 shots we can take for the flu,
Yes.
COVID,
Yes.
and RSV.
Yes.
Should we take them all together?
I don't recommend that.
Okay.
So.
Take 2 of them at a time?
So, yes, technically that is safe and available. You can take 2 of them at a time. Here's the flip side of that coin. Remember how I said when you take a vaccine, your body has a response? It's practicing building those antibodies, so most of us feel a little under the weather. If you take 2, you're going to feel even more under the weather. And so for some people, they're fine with that. They're like, yeah, I'm just going to hang out on the couch for a couple days. I'll be fine. Some people really don't like that feeling, and they want to avoid it. So if you tend to have a significant response to vaccines, I usually say do 1 at a time. But if you don't mind feeling crummy for a couple days, do 2 at a time. That's okay. Yep.
I have not had COVID.
Okay.
I've tested, but it's like waiting for the shoe to drop.
Yep.
Do people
natural immunity?
You know, the answer is science isn't completely sure. The question was, are there people who have just kind of a natural immunity to COVID and they're never going to get it? Some virologists or infectious disease folks will tell you, we think there might be. That being said, I wouldn't count on it. Nothing is for certain. And I always tell people to practice vigilance even if you haven't caught it yet. Yeah, exactly. But there is some evidence to say that there are certain genetic markers that make you more susceptible or less susceptible to COVID. So hopefully that answers that question. Yep.
You said not to take 3. Why?
Well, the manufacturers don't recommend it for one, and it's possible that your immune system would not be able to build all of those together. Yes.
If you take them one at a time, how much of an interval should there be between each one?
You know, that's debatable in the literature and between clinicians. I've heard some clinicians say space it out 2 weeks. I've heard some say space it out a week. I think it depends on frankly, what research you're reading and how you interpret the body's response time.
Another question, if you're not around little children a lot, how much risk do you have of RSV?
Well, it's becoming more prevalent. Last year we had quite an uptick, and we had a lot of older adults because it is quite easily spread. And so if one of your neighbors sees their grandchild and catches RSV, and before they know that they're ill, has lunch with you, then it's possible you've caught RSV.
Is there any order of taking the shots?
Most people will say get the one that's first available to you and start from there.
If we take 2 of the 3, which 2 should we take?
Oh, you know, again, it's kind of like the whichever one's available to you. If you can get your RSV and your flu first, go for it. If you can get your flu and COVID first, go for it. It's really a matter of what's available and just kind of getting going.
We're being offered 3 tomorrow, I believe.
All at the same time?
My doctor said go for it if you
Okay.
want.
And your doctor knows more about your health than I do, so I would follow what your doctor recommends.
I have a memo that will go out later today with some updates on Kaiser, which is not good.
Oh.
And Bartels let me know as well that they have not yet received the booster shipment as they expected. It is unknown if the boosters will arrive by tomorrow's event. For sure, the RSV and influenza vaccines will be here tomorrow. If the boosters do not arrive, I have asked Bartels to please give me another date in addition to October 27th, because I know how important these vaccines are. On Kaiser, unfortunately, after lots and lots of back and forth, Kaiser let me know late yesterday they will not cover the RSV or the booster here through Bartels. They are clearly starting to reduce the number of contracted providers, and they are trying to push their members to Kaiser clinics. And so their contracted provider list has shrunk considerably, including many of the Bartels providers. For the influenza vaccine, this is just ridiculous to me, but Kaiser shared that they will deny Bartels billing. And what you will need to do is you will need to submit the denied claim to Kaiser if you choose to get your influenza vaccine here tomorrow for reimbursement from Kaiser. I have a message out to Kaiser. I've been bounced around to 2 different representatives, still waiting to hear, and have put in a plea for them to send out a Kaiser vaccinator, and have emphasized that we have residents here with limited mobility and cognitive challenges, and we need to make this accessible. They indicated because our location is so close to Kaiser clinics, that's probably not a possibility. So I'm disappointed with the news, and I wish I had better news. So certainly the memo will come out, and I'll share the same information at the Residents' Council meeting this afternoon.
All right. If everybody is okay, we'll move on to talking a little bit about long COVID, because it is a concern for many, many people. Long COVID are symptoms that last longer than 3 months after you've had COVID. Many people feel not great and have some fatigue that lasts into 4, 5, 6 weeks after COVID. This is just a protracted case of COVID or a longer case of COVID. That's not considered long COVID. Symptoms lasting longer than 3 months, that's considered long COVID. Some people will develop their symptoms of acute COVID, get better, and months later develop symptoms that fit with long COVID. It's not necessarily something that lasts the whole time. It can kind of resolve, and then you develop symptoms later. It can be one symptom. It can be a multitude of symptoms. The primary one is fatigue. A lot of people, their primary symptom is significant debilitating fatigue. And I'm talking about taking a shower is exhausting, that kind of fatigue. Cognitive changes, mood changes. I've had a fair amount of patients who have new onset depression they never had before. I've had some patients who have what we call brain fog, a little bit more difficulty processing information than they did before they had COVID. Shortness of breath or air hunger, where you feel like you can't get a good breath, but every time somebody checks your oxygen or your lungs, they're fine. That's been kind of a featured symptom among long COVID patients. Dysautonomia, which usually manifests as dizziness. Kind of whenever you stand up, you get lightheaded. You know how if you've ever stood up too fast, you get lightheaded. Having that persistently is a symptom of long COVID. Neuropathy, nerve pain in your feet or your hands, and people who've never had that before. I'm sure some people in this room have some neuropathy from other issues, but having something like that after COVID is a prominent feature. What's called vasculopathy, and that's just a fancy word for inflammation of the blood vessels. You might have heard back during early COVID of something called COVID toes, where your toes would turn purple or blue. And those were called COVID toes. And basically it was a spasm or an inflammation of the blood vessels that would cut off circulation, and then it would come back when you warmed your feet. So anybody here have Raynaud's? Yep. It's a similar symptom like Raynaud's, where when your feet or your hands get really cold, the vessels constrict. So those are the typical symptoms. Let's move on. All right. So what causes long COVID? The short answer is we do not know. There are a lot of theories. There are scientists all over the world working very hard to figure it out. Prevailing theories are it's persisting viral circulation or just a persistence of that SARS-CoV-2 viral replication. Overactive immune cells may create excess inflammation in similar to an autoimmune issue or a rheumatoid condition. Similar reactivation of other viruses we've had. Some of you may have had kids that had mono when they were teenagers. That's usually caused by one of two viruses, cytomegalovirus or Epstein-Barr. One of the theories is that when you get COVID, your immune system is distracted, for lack of a better term, and the Epstein-Barr, the cytomegalovirus, can kind of reactivate. So those are the current theories. Who is at risk? We honestly aren't sure. Science is still working on that too. What we do know is in studies, retroactive studies of people who have developed long COVID, and then chart reviews of patients who had COVID, and then looking at them longitudinally to see what they developed, people who were not vaccinated were at higher risk. People with type 2 diabetes or other autoimmune diseases like rheumatoid arthritis, lupus, those kinds of conditions were more at risk, and those who were significantly overweight. People who had a severe course of COVID or were hospitalized are also at higher risk. And if you've had multiple infections, your risk increases each time. So another reason to try to avoid it. Preventing it. So again, we don't understand why it occurs or who necessarily is going to be a long COVID candidate, but avoiding infection is the best way to prevent it. Vaccination boosters and boosters and boosters help reduce the potential that you'll have that overactive immune inflammatory response by giving your body more of the cookbook, so to speak. And if you do get sick with COVID, allow yourself plenty of rest. Don't try and overdo it. Drink lots of fluids and talk to your doctor about treatment options. There was a study that came out very recently from one group, did a retrospective review of people at the VA, and those who took Paxlovid did have a reduced risk of long COVID. That's the first study to come out to show any evidence that it reduces your risk of long COVID. But it did recently get published, so that's there. So let's talk a little bit more about our psychosocial impacts. So during the pandemic, we all went through a really scary time. It was hard. And it changed a lot of people's perceptions of what risk means, what living in a community means, what it's like to think about our daily trip to the grocery store or wherever else we go in a different context. And that created a lot of different responses. We were all afraid. I don't know anybody who would say they weren't scared to some degree during the pandemic. A lot of people had experiences that were nothing they'd ever had before. Novel experiences usually are really hard to adjust to. Rates of anxiety and depression went up dramatically, and that persists today. Over 25% increase in depression and anxiety in the general population. Substance abuse went up dramatically, and that, again, persists today. So we're still dealing with impacts far beyond COVID per se. So increased division. Different people have different risk tolerances. And I think until the pandemic, a lot of us hadn't thought about what that looks like and what that means. Some of us are okay with a little bit of risk. Some people don't like risk, and it feels very uncomfortable, and they don't want to take risks. This really kind of illuminated where some of our preferences are that way. It changed levels of trust in healthcare and government for a variety of reasons, and we can certainly talk about that. The economic impacts still persist today. Our economy is changed, and it will continue to change as a result of the pandemic. So it's going to be that way for a long time. I had somebody say to me early on in the pandemic, it was a doctor that came to work in my clinic, something like this has never happened. This has never happened before. How many of you believe that's true? Yeah. There was an influenza epidemic that happened in 1918, I believe, and it was more catastrophic than COVID has been. So we have been through this before. And there were changes that happened because of that, and we'll still continue to change as we adjust. So that's the end of the talk. And I don't put references up because they're usually so small that nobody can see them, but if anybody would like my list of references, just let us know, and I will provide them.
Any further questions for Christina? Bill?
Just a little one. Sense of taste. Sense of taste.
Yes. So many people early on, whenever they developed COVID, and this was primarily a symptom with one of the first couple of strains. So what I like to call OG COVID. The original strains of COVID caused a lot of loss of taste. For majority of people, according to the evidence and my anecdotal clinical experience, that recovers. Sometimes it takes up to 6 months for taste to come back. I have heard of one patient who still says 2 years later that he cannot taste sweet things the same. but the rest of his taste has come back. So,
Yeah, pizza just doesn't taste
Taste
the same
right.
anymore.
yep.
Oh, please tell me what all those initials stand for after your name up there.
Oh, well, Ph.D. is my
I
doctor.
got that
Yeah,
one.
you got that one, okay. The other one is my board certification. It's adult geriatric primary care nurse practitioner. And then A.R.N.P is advanced registered nurse practitioner. So one is my degree, one is my board certification, the other one is my license. So there you go.
So do you foresee that we are going to have another incarceration, so to speak?
More and more as we get through this, I highly doubt that will be the case. I think that it would take a dramatic rise in the mortality rate for us to have to do that again. The primary reason for doing that was to keep the healthcare system from becoming overwhelmed. And I don't foresee, with the treatments we have now, I don't foresee that happening again. For COVID, I can never predict if there's another one of these that's going to happen.
Let me,
When I had COVID, I guess I was in isolation for 10 days, and all I did is I just popped vitamin C pills, and I didn't have hardly any symptoms at all. I didn't feel bad at all, so I considered myself very fortunate.
There are some people who don't, their body either for whatever reason, like I said, there are genetic markers that predict a better response to COVID or a worse response to COVID. And we can't kind of map everybody's genes. And some people just are lucky and their body efficiently fights it off. So it's great when that happens.
Now I'm getting test kits from all kinds of organizations. I didn't even ask for them.
Oh.
I had about 5 test kits
Goodness.
in my apartment. I thought, well, I don't need those. I'm okay. I'm fine. So I donated them to
Good.
supported living.
Good.
I'll add, one of my takeaways so far from this is the utter importance of testing promptly after getting any which kind of symptoms. That is striking me as the way that this community can do a great job of keeping us away from the feared lockdown and higher level restrictions. And I'm sure Lauri will address that at some point, either today or in the meeting tomorrow. Any other questions before we move on to our discussants?
Is there any length of wait time between the last booster and getting the new one?
The recommended amount is 6 months.
So if I had one 5 months ago, I should wait another month? Or
Correct.
Okay,
Yes.
great,
Yes.
thank you.
You're welcome.
I have a question about the longevity of the new vaccine. Does anybody know how long it's going to be effective?
So it's much like, at this point, what we know based on the tests, it's much like a flu shot. The prime protection that you're going to get is between 6 months and 9 months, really. And that's why we do the flu shot every year. So whenever we get our flu shot in the fall, it protects us the most for the flu season. That's 6 months. We still have a little protection for a couple more months, and then we have to get it again the next year when it all ramps up again. The prevailing wisdom is, and all of the research that we have suggests that COVID will be much the same. It's going to continue to circulate in a somewhat seasonal pattern, even though that seasonal pattern hasn't quite settled out yet. The approach that the manufacturers and the CDC are taking is a once-a-year shot. Now, they did release a new booster back in the early spring, late winter last year. And so that there's still a lot of research ongoing trying to determine, do we need to do 6-month boosters for people who are at high risk, or do we need to do once a year boosters just for everyone? And that's yet to be determined, to be honest. Yes.
Is it possible to have COVID and be contagious and yet be totally symptomless?
Yes. Absolutely.
So there's no way to control it from spreading in that instance.
That is why it's such a risk. And that is one of the reasons why we all wear masks or wore masks for so long and asked everyone to wear masks for so long. Yeah.
Christina, I know that the FDA, when they announced the new fall COVID booster, they mentioned at least 2 months. I know that for a lot of our community, they received the last bivalent booster in April, which
Okay.
puts us at 5 months. Can you share a little more about that 6-month recommendation?
So that 6-month recommendation was from the manufacturers. And I think that it's probably, you know, if I were to go back and read that recommendation, I'm sure there is a variance of by a month. So 5 to 7 months. They were thinking an average of 6 months, I'm sure. But like I said, I'd have to go back and read it again.
Would you like to come up and comment?
Comment. The official recommendations from the FDA were that at least 2 months after after you were boosted the last time, and at least 3 months after a natural infection.
Okay.
I have a question about masking. So I don't know when in this past summer, maybe there was this great Cochrane study that said masking doesn't work, and all the anti-maskers in the world jumped on it and said, see, finally proof masks are just stupid. My reading of the whole business was that it was a crappy study, but I'm not any expert on that. It seems logical to me that a airborne thing going through several layers from me to you would cut down on whatever I get, but I'm wondering how you view masking.
So I've read that Cochrane review. To answer your question, how I view masking, it doesn't hurt, and even if it prevents one case, it's worth it. I now am personally calculating my my personal masking with where the risk is. My clinic removed our masking requirement a couple months ago. I still mask every time I see a patient. And that reason, that's because most of my patients are vulnerable in some way. Either they have multiple health conditions that put them at risk, or they have other issues that would make COVID more severe. So I mask in clinic still. I also don't want to bring anything home to my family. That being said, the greatest protection from masking is those around you. We mask so that the people around us are at less risk. It does give us a degree of protection, but it's more for the other people. So that's my personal view on masking. The Cochrane review was an aggregation of studies, as they all are. You know, observational data is challenging. It's just challenging. If we're not tightly controlling an experiment, what kind of mask are you wearing? How are you wearing it? How often are you wearing it? How often do you take it down? Those things are important in order to know how effective it is. Right, what kind of mask? Yes. So all those factors go into it. So observational data, I think, is challenging. What it did show, that Cochrane review, just for what it's worth, is that hand hygiene was the most effective preventative measure for viral transmission. So everybody who carries a little pocket hand sanitizer washes their hands frequently. That was considered the best preventative measure. So I'll add that to that. Yes.
Really, to add very little, it was an excellent presentation, and combined with the questions from the audience, why I think we've covered almost everything. There are just a couple of things perhaps to emphasize that you already mentioned. I was going to add the same thing about the mask comments. The Cochrane studies were flawed, and the interpretation of them was flawed. And I think that the value of masks, most people would agree, is considerable. And it also, I think, has reached the point where these are individual decisions that each of us has to make based on our analysis of the risk that we're likely to experience, and be prepared to carry a mask with you and pop it on when you need it and take it off when you need it. I just reflect on my own activities in the last week. I went to the Husky football game, and I used the subway or the rapid transit to get out there, and we were packed together like sardines, and I was glad I had my mask on. When I was in the stands, I didn't wear a mask, and I think that we can all, we all are a little bit different in terms of how we analyze these things, but it should be part of our thinking. The other thing to emphasize again is the hand washing, which you certainly just did. Just a couple of additional comments. One would be because the value of Paxlovid has clearly been established, it would be a good idea, I think, for all of us to have a strategy in mind as to how we're going to get Paxlovid if and when we need it, and to have a discussion with your primary care provider about that ahead of time. And the same thing would be true for the Tamiflu, but particularly for those two drugs, you may need it. You need to start them soon once your symptoms begin. So that's the reason to be prepared and to have a plan in mind. And the other thing, which is a small point, but we often resort to anti-inflammatory drugs for symptomatic care, and this is certainly appropriate with these diseases. But a word of caution, and that is that aspirin and influenza don't agree with each other very well. People are at some risk for an acute liver injury if they take aspirin for a fever when they have the flu. So in general, acetaminophen would be a much better choice. Avoiding aspirin altogether is probably the best thing. It's also better on your stomach if you do that. So,
all the NSAIDs?
No. The other NSAIDs are much less likely, have not been associated with that acute liver injury. So aspirin is the only one, and it was recognized in the late 1960s, particularly in the pediatric population. But adults are at risk as well. So that's all I'd like to say.
I'm just going to add one more thing to what Dr. Wallace said. So with the masking, there was a study that came out early in the pandemic that showed, and they were specifically targeting the transmission of SARS-CoV-2 in a enclosed room between people who were masked and or one person was masked. There were 4 arms. When both people were masked, the transmission was reduced to 3%. So if all people are masked, transmission does reduce according to those studies. So, but again, that was tightly controlled, and the people were wearing well-fitting masks that were surgical masks, not cloth. They were covering their mouth and nose and close tight to their face. So I'll just add that.
Quick question. I know that 2 residents had shared with me that they were able to obtain a Paxlovid order prior to travels. Mm-hmm. How readily are providers willing to prescribe Paxlovid in advance of having COVID?
Yeah, so that's a really, amongst providers, that's quite a touchy subject these days. I have provided it to patients of mine when they're traveling. I have a lengthy conversation, I'm sure much to their dismay, about the risks and benefits, when it can be used, when it shouldn't be used. And kind of general precautions that way. The bottom line is, I think it's okay to provide it when people travel. I think it's okay. I've prescribed it for some of my high-risk patients during the holidays last year, just in case. But I'm very, very adamant that you have to have a positive test before you take it. That's it.
And another question is, while we have a very, very high vaccination rate here in the Horizon House community,
yes,
I read a literature recently that said only 17% of the population obtained the last bivalent booster. What messaging could you recommend we share with family, friends, colleagues outside of the community? Some have said there's not enough research to verify my comfort level in obtaining a booster. What can you recommend?
What I usually say is, you know, the boosters have been well studied. There is extensive research done on these boosters before they're put out. Their safety record is solid. And then on a personal level, it does reduce viral shedding. And so it protects those around us that we love and who are vulnerable. And so, you know, one of the reasons I get frequently boosted is to protect my patients and, frankly, my parents. Because they still want to see me and I still want to see them. And doing what I do, I do put them at greater risk. So
I'll just make a couple of comments, and then when I see we have more questions. One is, as I mentioned at the last fireside chat, the home test kits. Christina's really touched upon the importance of testing at the onset of symptoms. I mentioned at the last fireside chat that unfortunately with the public health emergency having ended in May, that has sunsetted all of the free test kits. Many insurance companies are covering test kits. That's something you need to check with your individual insurance plans on. And if your insurance plan does not cover the cost of home test kits, as I shared before, treat the home test kit just like you have a box of Band-Aids in your medicine cabinet, like you have a tube of Neosporin. You never know when you may start those symptoms, and that treatment is so vital if it is confirmed positive for COVID. And just to emphasize, if you are experiencing symptoms, please begin isolating, because again, as we've seen among some of you, you're not converting, in some cases, to a positive test result until 2, 3, 4 days into active symptoms.
Looks like we're done. I want to thank heartily Christina for coming and giving this presentation.
Thank you. It was great to be here. What I didn't mention is I did a in-service workshop for the staff in the memory care section 13 years ago. And so it's really nice to be back. It's probably one of my favorite communities in Seattle. So thank you for having me.
Thank you. And Christina will be available for conversations for the next 15 or 20 minutes. We'll be hanging around in the room. Thank you, Lauri, and thank you, Findlay, for joining in and lending your expertise and information. Have a good day, everyone.